So thank you for attending the CAHR special session entitled Using Administrative Data to Support the HIV Cascade in Key Populations. So I will be co-moderating this session with Dr. Bob Hogg. In this session, there will be discussions on the challenges and opportunities in routinely collecting and using data on access to HIV care and the care cascade in several key populations, such as Indigenous people, immigrants, Black people, people who inject drugs, people who are in prison, for example. Today, we have 5 panelists, and our panelists come from different provinces. They all report on administrative databases or large cohorts. So our panelists are Abigail Kroc from Ontario, Viviane Lima from BC, Alexandra de Pocamandi from Quebec, Sid Cogill-Waymat from Saskatchewan, and Lee McClarty from Manitoba. I want to remind everyone that we're going to have a Q&A session at the end of the discussion of 2 topics. And remind you that during the Q&A session, we would appreciate it if you could let us know who you are and who your question is for. Would you like to add anything, Bob?
I have nothing to add. Thank you.
Perfect. So let's get going with the first discussion topic. The question is, what data are routinely collected in your province? What cohorts exist, and how can researchers access these data? And let's start with Abigail.
Hi, Anita. Thank you so much. And thank you for the invitation to be here and talk to you all today. So I'm Abigail Kroc. I work in Ontario. I'm the Director of Data and Applied Science Impact at the Ontario HIV Treatment Network. I'm the Principal Investigator for the Ohtn Cohort study. I'm also an Adjunct Scientist at Public Health Ontario. Starting off saying all that kind of connects me to the data that I'll be talking about. In Ontario, we have a richness of data, but not all of that data is linked to each other. So all HIV and viral load testing are conducted by the Public Health Ontario Laboratory. And around 2014, these data were linked within an HIV data mart that allows for the linkage of diagnostic and viral load tests. And that's what allowed us to examine the care cascade. We began publishing Cascade data back in 2015. The data from the HIV test requisition form and a follow-up form we use in Ontario for positive tests only that we call the Laboratory Enhancement Program form. Those are also uploaded into the data mart. So that includes all of the risk factors and also race ethnicity data. So this is our best data set to measure population level outcomes, as it includes all people who are diagnosed in the province. I should mention that we also have anonymous testing in Ontario. So for people who test anonymously for their diagnostic test, it is not possible to link them to their subsequent viral loads. So there is, of course, missingness in data for risk factors and race ethnicity, as these data are collected as part of data of clinical care, and data collection standards have changed over time. And of course, depending on the setting, these data are collected to higher or lower levels of standards. This data is accessible, but a researcher must apply to Public Health Ontario to access the data. It can be provided within the confines of the protocols of PHO and their privacy requirements, but at no cost to the researcher. We also have a longitudinal open cohort study that started in 1995 called the Ohtn Cohort Study, or OCS. Patients enroll at participating clinical sites, and currently there are 15 clinics that support the OCS within all health regions of Ontario. Clinical data is collected through charts and electronic labs, but we also conduct an interviewer-administered questionnaire on an annual basis that asks a variety of questions about previous HIV exposures, ongoing behavioral risks, mental and physical health, engagement in medical care, social services, as well as special tools that we introduce based on feedback from the community in particular. So we're looking at things like preparation for retirement and experiences of discrimination. These data are governed by a committee of people living with HIV, and to access the data, you must submit a proposal and respond to the feedback of that committee. Once approved, the data is provided at no cost to the researcher. Finally, there's the Institute for Clinical Evaluative Sciences, or we call it ICES. ICES houses many linked data sources in Ontario. Tony Antonio developed an algorithm to identify people living with HIV using billing codes. And these data are linked to healthcare utilization, mortality, and a growing number of laboratory tests as our Ontario laboratory system is integrated there. Our cohort study data is also linked at ICS to permit additional analysis. And with the approval of the governance committee, that linked data set can be accessed through the submission of a proposal, but at a cost to the researcher. So that's kind of the broad spectrum of what's available in Ontario.
Thank you, Abigail. So let's check in with the other panelists. Alexandra, do you have anything you'd like to add?
Yes, so I'm Alexandra de Pocomendi. I'm HIV care provider at MUHC and clinician scientist at the RIMUHC, associate professor at the Family Medicine Department of McGill University. And I'm also the director of the Quebec HIV cohort. So in Quebec province, HIV is not part of the mandatory program like the other infectious diseases, but there is a programme de surveillance since 2022 in which all confirmed serology that are confirmed positive at the Laboratoire de Santé Publique du Québec are transferred to the provincial public health director in a non-nominal fashion, and then an intervenant actually calls the physician who ordered the test to ask collect some question on epidemiologic data, including age, sex, region. There is country of birth, there is some ethnocultural questions on whether indigenous or not, and some other questions on symptoms, NC4 and viral load. Cases without RAMQ are also included since 2012. All information is non-nominal, and it's collected anonymously, so you cannot actually usually connect that to any other clinical data, except there is presently a research project led by Cécile Tremblay and Madeleine Durand, which is collecting, is going to link the data with LSPQ serologies, the viral loads, and RAMQ data, which will have some of the medication list for about 50% of the population. We also have the Quebec HIV cohort, which was previously called the Cohort Montréalaise and includes all people living with HIV, followed at 4 large clinics providing care for HIV in Montreal. CHUM and McGill University Health Center and Clinique Médicale L'Actuelle and Clinique Médicale Urbaine du Quartier Latin. And starting this year, we actually modified the protocol for now updating the data merging every 6 months and actually have more of a current data, and also help us clinically to improve the cascade of care using it through a learning health system. So that one of the limitations we have with that is that it's clinical data. We are missing the information that is not appearing in medical charts. But we do have a process in place for data request forms. You can reach out to me if for more information in sake of time. And I think I will stop there for now.
Thank you, Alexandra. Lee, would you be able to add something about Manitoba?
Yeah, absolutely. Thanks. So I'm Lee McClarty. I'm a postdoctoral fellow at the Institute for Global Public Health in the Department of Community Health Sciences at the University of Manitoba on Treaty 1 territory. So yeah, I can briefly sort of touch on the 2 main sources of HIV data we have here. So we have 2 main cohorts. The first one is what we call an administrative cohort, and it includes folks who've been identified as living with HIV based on an algorithm that we just developed locally using our provincial administrative databases. And Manitoba's administrative data sets include individual level records for nearly all contacts with the provincial healthcare system. So this administrative cohort comprises those data, and sort of some of the key variables we focus on are within the cohort are physician visits, hospital admissions, pharmaceutical prescription dispensation, and other lab tests aside from HIV. So that would include things like hepatitis C, tuberculosis, and STIs. And we have data on both testing and results of those tests. The other cohort in Manitoba is an open clinical cohort, and this one, for enrollment in this one, people are approached in the context of clinic visits with the Manitoba HIV program, and then following an informed consent procedure, or process, we ask for permission to collect some data from their medical records that are used in the clinic setting. So, and then these clinical data are linked to using a de-identified sort of complicated mechanism, but at an individual level are linked to all of the administrative health data that we have in Manitoba. So the clinical records that sort of supplement the administrative data in the clinical cohort include additional data like CD4 counts, which we don't have collected provincially, and as well as some info on self-reported HIV exposures or primary exposures, self-reports of alcohol and drug use, and some other more detailed demographic information that's not collected by the sort of provincial system. So having access to these additional clinical data to supplement the admin data is really helpful for us when we're trying to create sort of more refined indicators for indicator definitions for each step of the cascade when we're doing it for Manitoba. So we're able provincially to develop a sort of more specific or nuanced cascade that model than the data we'd provide to FAC for the national models. And then I'll just add that in the context of these Manitoban cohorts, I think we're still really struggling to find a perfect solution for routinely and systematically identifying members of priority populations. I do think the clinical cohort is a little bit of an exception. We do pretty consistently identify priority populations that are sort of categorized based on demographic characteristics, at least, so race or ethnicity. But honestly, we just don't have enough resources in Manitoba to maintain these cohorts fully and to be able to sort of dig deeper into start doing surveys and stuff to get more detailed and helpful data in that way.
Thank you, Lee.
Yeah.
If that's okay, I'm going to stop you here, and if we have some time, I'll come back to you later. Thank you. Next, can we hear from you, Sid?
Hi, everyone. My name is Sid Koval-Wyman. I'm an infectious diseases physician from Saskatchewan. I work out of Saskatoon and northern Saskatchewan in a place called Prince Albert. I mainly provide HIV and Hep C care to these communities. I normally reside and work on Treaty 6 land, but I'm coming to you guys from the traditional unceded territory of Syilx and Okanagan people. I'm in Kelowna for the week, and thank you for having me. So I have to say I'm really awed by the answers from my colleagues in Ontario, Quebec, and Manitoba, because I feel like in Saskatchewan we're kind of in infancy compared to the other provinces. I will start by saying HIV care in Saskatchewan is fragmented with different providers, different EMRs. And that's one of the biggest challenges that we had in developing like a database. I think the best cohort / database would belong to Dr. Alex Wong in Regina, but outside of that, I think the rest of us kind of work on our own little silos until recently. We all decided to come together to develop a database of all patients or all people with HIV seeking care amongst Saskatoon providers. This is the first time this has ever been done. And so some of our data has been presented at this conference, and I presume that that was my invite to this panel. And so, again, I think like with any databases that get established, it took us about a year to kind of get it established. We've started very basic. We collected with patient-reported risk factors, patient demographics, initial viral load, CD4 counts, the factors required for care cascade, calculations and data. And actually, we're presenting the care cascade data at this conference. I have to say, it was quite eye-opening to finally look at data, although we did suspect we were quite, doing quite poorly. But hopefully, this would act as a first step for us to, establish a province-wide network, a province-wide database, because we're small enough, but we're geographically quite apart, so that makes it challenging, I find. But hopefully this will be a first step in developing a province-wide database, work with our provincial lab, which is the focal point of all HIV testing in the province. So it's easy starting point, I think. and eventually, hopefully, establish a cohort of persons with HIV in Saskatchewan, because we have a very unique epidemic. And I think the answers that we get from understanding our population will serve, I think, at least the prairies, if not, very unique populations across Canada. Yeah, and that's my take.
Thank you, Sid. Vivienne, would you be able to discuss BC, please?
Yes, hi, I'm Viviane Lima. I'm a research scientist and senior methodologist at the BC Center for Excellence in HIV/AIDS. I'm also an associate professor at the University of British Columbia. So at the center, we host two big databases. I'll talk about both, but I'm gonna be very specific about one of them. So we have the COAST study where Bob is the PI, and we have the Stop HIV/AIDS initiative. And mostly of the information we give to PHAC comes from Stop. And so Stop, for short, we know, basically we follow people since we know their HIV positive status, right? And we get information from the BC Center for Disease Control, or we get information from the drug treatment program, which is at the core of all these databases, which is a registry of people in BC who have ever assessed the treatment or HIV care through the center. And we have like clinical data, complete antiretroviral data on those individuals. And we also collect several social determinants of health through different means, right? We don't have a systematic way to collect some of the information. And basically the other people that makes Stop, it comes from administrative data that the BC Ministry of Health links to the DTP, right? And basically, we follow people from 1996 until the latest that can be provided, like data that can be provided to us. And through the DTP, we have very regular linkages with vital statistics. So we know the status of the person in BC. And yeah, and basically we have hospitalizations, physician visits, Pharmanet, which is the non-antiretroviral part of the medications that people use, and several other databases. And yeah, through that, basically, we can kind of identify, basically estimate who is living with HIV in British Columbia. And we have, as a way to keep people updated of what is going on in BC, we have quarterly reports from the Stop cohort that are uploaded in the BC Center for Excellence in HIV/AIDS website. So you can see several statistics about testing, antiretrovirals, how early people are starting on treatment or how early they are testing for HIV. If we have AIDS case, there's a lot. We are in the process of changing a little bit this report because our population, more than 50% is aged 50 years and older. So we have to start monitoring other, indicators like comorbidities, because that's quite important and can affect some of the outcomes. And our data is not accessible to people that are not at the center because of the way we have ethics and the way the Ministry of Health agreed, right, to share the data with us through the linkages. But we are very active in terms of trying to describe the population. Yeah, so far that's what I can say about Stop. And basically that's the information we give to PHAC when they needed to estimate the 1999 or the incidence of the prevalence. So that's what we give them.
Thank you, Vivienne. I'm just going to check back in with Lee. Lee, is there anything else you'd like to add?
Oh, thanks. No, not really. I was just going to quickly say that in terms of accessing data for Manitoba, we can use, probably the easiest way is just to reach out to either me or to Dr. Marissa Becker, who's the lead on these cohorts, and we are more than happy if anyone's interested in taking a look at the Manitoba data. So yeah, thanks.
Thank you. So we are a little bit ahead of schedule, which is great because topic 2 is a really rich question, and Bob will be able to take the lead on that. So thank you.
Thanks very much, Anita. Yeah, we have a bit more time for this one, so you can, the panelists can spend a bit more time on their answers. So the topic is broken up into 2 questions. So the first questions, and we probably, what we'll maybe do is I'll read both questions and then you can respond to both at the same time. So topic 2, are you aware of any disparities in the access to HIV care and outcomes in the HIV care cascade in your province? And the second question is, which subpopulations are most affected, and how does this impact Canada's progress towards meeting the UN AIDS 95 goals? So Viviane, we're going to go in backwards order. So Viviane, would you like to start? There was actually 3 questions, but I said,
Thank you, Bob. Yeah, so I can give you some statistics, right, for BC. PHEC has estimated that in 2018, BC was in the 92%, 91, and 94% in terms of the UNAIDS target. And in 2020, we have some preliminary data that tells us that, you know, we have 94, 92, and 95%. But, you know, there is a lot of work that we need to do, because when you open, you know, each one of these targets, or even if you look at the overall cascade of HIV care, you can notice that it's very heterogeneous how you look at it, right? There are several groups within our population that are not doing so well in comparison to others. So we see that, for example, females, they do not reach the targets as fast or as high as males in our population. We see discrepancies in terms of age as well. Young people, they tend to have a little bit of a hard time to be diagnosed, be on ART and be suppressed. But we also notice that those who are above 50, although lots of them, they test late for HIV, and also sometimes they start late for HIV, they do well once they are on treatment, right? And so other groups that we see that, you know, more should be done so that they can really, you know, we should reach them, right? So we see people with substance use disorders having a little bit of a hard time in terms of, you know, achieving the UNH goals. Like we see ethnic minorities as well, and people with mental health. Those are some of the vulnerable groups that we see that when we stratify the data, they are not doing so well. But one thing that I should say is like we have various initiatives, right, in British Columbia to make sure that you know, people get tested. If they want to start treatment, they start, and we have support for them in terms of being adherent or achieving viral suppression, right? There are, you know, various initiatives. Some are related to the Stop HIV/AIDS program. We have like integrated care clinics, right, for people who need more complex care, more complex follow-up, so that you know, they can benefit from antiretrovirals like anybody else. And also, you know, BC and Canada and other places, we are experiencing the overdose crisis, right? And unfortunately, several people have passed away, and they were doing so well, right, on treatment suppressed, but unfortunately, you know, they're not with us anymore. And so there are initiatives to kind of make sure that those are preventable deaths, right? So that we can support this population that needs support, so that you know, they're alive and with as much quality of life as they can, right? And we have like different studies like CHIWAS. There are several studies and initiatives to give support to women, right? In terms of making sure they can benefit also and have a better quality of life and live life normally, right? Without even thinking about, you know, they have HIV. So there are several research studies that are really important and several cohorts that really provide us information that we can use so that we can help these groups, you know, achieve this 95, 95, 95, or even we want like 100, 100, 100, right? Yeah, so it's important that we identify who is struggling, right? So that we can help them in any way we can. So that is the reality in BC.
Thank you very much, Viviane. I said I was going to go in order, but I, based on the list here, it's Leah. Sorry, Leah.
Sure, thanks. So this is a really interesting question for me personally, but also I think generally people thinking about HIV care in Manitoba are very aware of issues of equity or inequities in care broadly and specifically around the Cascade. So the reason it's interesting to me specifically is because this was a really large part of my dissertation work that I did a couple of years ago. And basically what we were able to do is use the data from the clinical cohort that I talked about earlier and then use sort of an iterative and collaborative process with folks at the Manitoba HIV program to develop some contextually relevant indicators for each step of the cascade. And then from that, I was able to create disaggregated care cascades for people in the clinical cohort. And we were able to disaggregate by age, sex, geography, ethnicity, immigration status, and self-reported exposure category. And really, I think that the sort of richness of the data that we have available to us in Manitoba and through our cohorts was extremely helpful in terms of being able to look at a number of these key equity variables. So I won't take tons of time to talk about the specific inequalities that we saw across the cascade, but just to kind of summarize, we did absolutely identify and quantify a number of them across each step of the cascade. And I think it's pretty hard for us here to definitively say which subpopulations are most affected by these inequities and the inequalities at each step, but really they all feel fairly unacceptable at this point, to be completely honest. But overall, our analyses highlighted that participants who are younger, so in the 18 to sort of 39 age groups, non-white, those who had immigrated to Canada at some point, and those who identified injection drug use as a primary HIV exposure were all at lower odds than their counterparts of reaching subsequent cascade steps. So their engagement and across the entire cascade was suboptimal. And I think, so just listening to Viviane speak about some of the trends that are seen in BC, I think that we have, I mentioned in Manitoba, we're also seeing younger folks having a harder time engaging at each step. Interestingly, we have almost no difference between male and female participant or like cohort participants in terms of their engagement. And I think that's probably not surprising to folks who know or are familiar with the epidemiology of HIV in both contexts, but in terms of ethnicity, it was sort of honestly a jumble. There was no clear trends for other than folks who are white are doing better, and that's probably not surprising to anyone either because of numerous structural and systemic barriers to non-white folks. And those disparities are generally across the cascade. We see more of them emerging in later steps of the cascade. So inequalities in suppression, virologic suppression is really more common than inequalities in, for instance, getting linked to care or being retained in care based on our definitions. So, and just to quickly speak to the last part of the question around the 95 targets, I think, so in Manitoba, we haven't spent a lot of time focusing on the targets or sort of comparing our progress to the targets, to be frank, but I think my impression generally is that we need to, the focus on equity here is really the most important part if we want to start seeing improvements in the 95 targets for the nationally for the country. And I think at this point, really, there's just an ethical imperative for Cascade researchers in Canada to be actively focusing on and contextualizing their work so that it can provide relevant information to care and prevention programs to improve service delivery and address these drivers of the inequities that all of us are really seeing across the cascade. So,
well, thank you so much. Yeah. Abigail?
Since this is we're talking about administrative data and this is an epi session, I just want to point out that there are real challenges to estimating the care cascade and to comparing across jurisdictions. We all have different data sources. Those data sources have different biases, and those can lead to differences. And once we set a clear target, you know, it has to be 90, 90, 90. We all know who do this work that those are ranges. And, you know, it might be a range of 87 to 92, but what matters is if you hit that 90 number, because that's what targets set. So targets in general like this are a real challenge to epidemiologists, I think, because, you know, for us, you know, I think we prefer to think in ranges and reflect on the limitations of our data. So in general, there are systematic problems with this, but there are also particular problems, which is that people who do not connect to care or are lost to care can't be distinguished from people who left the province. So once someone is not in care, it's very hard to know how to include them in your numbers. So because of this major issue, you end up undercounting people. You either are undercounting people who are not in care or you are overcounting them. And that is a real issue because those are the denominators that you need to calculate the 90-90-90. This particularly impacts the percent on treatment, because you have to know how many people are living in the province, you have people who are leaving the province, and you also have people passing away. If you don't have a fully linked database like they have in BC that includes mortality data, which includes Ontario, where we don't have that information, we use a loss to follow-up rule saying that, you know, if someone hasn't been in the province for 2 years, we consider them probably no longer in the province. We have sensitivity analyses around that, but that means like at that point when someone dies, they could be counted for 2 more years. And if that's a number of people, and as the cohorts age, you know, that this error is becoming more important. And at the same time, we're trying to get more and more granular on these targets. Because most likely to be able to say that we have 95% of people on treatment, we need to have a very low error rate to be able to hit that target. So just throwing in some of the challenges that we're having, and honestly, like, you know, these numbers are being reported internationally and are being shown to reflect on our programs. And often they're compared to cohort studies they're having in the clinical environment where people who are not in care are not even counted at all. So it can often look like those places that have better data are actually doing worse on the cascade. So that's enough of my rant about data quality and its impact on these targets. But we have been able to do some analysis looking at subgroups. In 2020, Ontario came close, but had not fully met the 90 targets. Our target, we were 89, 87, 98. We have seen improvements over time and a closing of gaps between different subpopulations. So we're still analyzing the 2020 data. So the rest I'm going to be referring to 2018 and other historical data. So like the other jurisdictions have already discussed, and that's been documented many times, women and younger people do slightly worse in the care cascade. We see differences by exposure with people who inject drugs and people who reported heterosexual contact exhibiting lower outcomes than those who reported male to male sexual contact. We see differences by geography, with people in Northern Ontario experiencing lower cascade outcomes. It's important to know that our race data is limited, but we were able to look at a care cascade for African, Caribbean, and Black people. We did not see very large differences in the 90-90-90 targets, but we did see that ACB folks were less likely to be linked to care and took longer to link to care than Ontario's overall. We're currently working with Indigenous researchers and community members to better understand the care cascade for that population. And we hope to share that data later this year. So I can't comment on that at this time. I think in order to meet the more aggressive 99, 95, 95, 95 indicators, we'll need to better understand the data, the error in our data, but programmatically focus on getting more people diagnosed and on treatment. We do very well on that third 90 once people, and the drugs, the drugs are good. So once people are on treatment consistently, they're able to achieve viral suppression. And we actually, unlike what Lee was saying in Manitoba, we see fewer differences for the third 90 than we do for the second 90. But when we look at our cascade data in the OCS, we find that people who struggle paying for meds do worse in the care cascade, and people living in poverty. We know that people living with HIV have complex needs that extend well beyond their HIV care, but include housing, food, security, and mental health. I believe that we must ensure that these people with the most complex needs have additional supports to maintain their treatment in order to reach our targets. And finally, viral suppression alone is not enough to reach optimal health. We must also measure other quality of life indicators and the impacts of HIV stigma and discrimination on the health of people living with HIV. Using our cohort data, we're currently trying to establish these metrics, and so that we can use a common metric on an annual basis and establish a target so that we can look at these kind of more nuanced health measures.
Thank you very much, Abigail. Alexandra?
Yes, thank you. So it's very similar issues and observations in Quebec. I'm going to talk about the last cascade of care that was done using the cohort in 2015 by Blake Lintwit and Dr. Joe Cox. Basically, they examined people who were engaged in care in the participating clinics in 2015, and that was 6,364 people. So again, we do not have the proportion that represents among all people diagnosed. Among those, 97% were prescribed antiretroviral, and of those, 92% of those using antiretroviral or prescribed antiretrovirals, 92% were virally suppressed. But like Abigail was saying, these are people in a clinic setting and being seen. So we know this is a bit of an overestimate. Now, overall, it seems that the target is met, but when we look at more priority groups, and the groups that were examined were men who have sex with men, people who inject drugs, people who are from HIV endemic areas. There's other heterosexual people not part of the previous group, and people age 15 to 29, like age and that kind of categories, and sex. And it seems that all priority group met the 95% target for having antiretroviral prescribed, except the young adults group, the people aged 15 to 29, only 93% had that, according to that data. So, and when we're looking at the virally suppressed proportion, then all group met the 90% target, except exactly like was said by observed in the previous provinces. It's the people who inject drugs, young adults, so the 15 to 29, and females. And of course, these are not exclusion categories, like people can belong to all of these groups. So, but they were all, 88% of all of these groups actually had met, were virally suppressed. So we're not far. It's it's not meeting the target, but helping to find areas of improvement. Unfortunately, we're not able to conduct analysis more specifically by gender or ethnicity and race. And there's all these other social determinants of health, like were mentioned, that, you know, income, housing, education, we know have a large impact on remaining engaged in care and reaching the cascade of care outcomes. And it's very difficult because it's challenging because we're using clinical database. So we have to have the information in the medical records. But we are working with the Quebec HIV cohort exactly on that to kind of help identify or improve the data that we have to have a better idea. And one important variable is what was mentioned by Abigail, like the loss to follow-up. Are they really lost to follow-up, or they followed at a different clinic, or did they move? So we're starting by trying to document that a little bit better. Generally, it's somewhere in the medical chart. It's just not regularly targeted in the clinical database. But I think this is very kind of an important variable that if we can help each other to first identify the people lost to follow-up, to re-engage in care, you know, while we're trying to get the right statistics, still trying to improve it, but also try to get a better picture for the denominator. So I think I'll stop there for now.
Thank you very much. Sid?
Thanks again. I think I'll start with probably the PHAC data for 2018 for the 1990 numbers for Saskatchewan. We have 72% diagnosed, 89% on ART, and 76% suppressed. So a far cry from other places. And compared to 2016, we're fairly similar at 70, 91, and 77% in 2016. I mean, I think I have to say, like, you know, the epidemic in Saskatchewan is unique. If you just look at last year's numbers, we are like 2.5 times the national average for new diagnosis. And 61% of our new diagnoses are in people who inject drugs, compared to 7% in gay, bisexual, and other MSM. And we have probably one of the highest co-infection rates with Hep C in probably North America, if I'm not mistaken. It's around 80%, 70 to 80% co-infection rates with Hep C. Nearly half identified as Indigenous, and this is a drop from around 70 to 75% the last few years. And I think, as Mona Luffy, very clearly pointed out this morning at the Dr. Mark Weinberg lecture, there's a feminization of HIV in Saskatchewan. 55% of our new diagnoses were of women, and 8 out of the 10 were of childbearing potential. So, like, again, very young women, people who inject drugs. Again, our key populations are fairly similar to the ones that were described by my other co-panelists, but I think we're probably facing a disproportionate challenge in Saskatchewan with very few providers. There's about 6 or 7 HIV providers, ID HIV providers. There's a few family doctors who are keen and really do an amazing job. And so you can appreciate the overlapping syndemics of, like, substance use, poverty, lack of access to healthcare, partly due to our geography, but also a lot of stigma. There's violence, there's homelessness, incarceration, the lack of education. So there's a lot of other factors that go along as well. I mean, in 2022, I still see young people dying with HIV in their 30s and 40s. That's just heartbreaking in so many ways, but that's the reality. I still see stigma in the hospitals. I still see pregnant women diagnosed like at the time of delivery. Such missed opportunities in many ways, every time I try to send a patient to the hospital for their opportunistic infection, they refuse to go because they don't want to be subjected to, mistreated at the hospital is often what I hear. So there's a lot of challenges that we face, and some of it overlaps with understanding the epidemic, but also some of it is just systemic inequities. And so one of the things that we highlighted this CAHR, in our poster is the different care models for HIV that's available in Saskatoon. So one's hospital-based and one's clinic, like a community clinic-based, which has access to primary care docs, opiate agonist therapy, lots of there's dental clinic downstairs, there's a psychiatrist available, I go there as well. to provide ID care. So we treat endocarditis with oral antibiotics, like, you know, the usual, like sort of what we have to do out of the box kind of thing. Our last 90s, 31% in the hospital compared to 50 in the community. Again, our numbers are by no means something to be proud of by any means, but it was an eye-opening experience for us just to like know that we're not doing so well, and trying to identify how we're gonna like go forward from this pandemic, you know, the pandemic that overlay another pandemic. So we just need to like we have made huge strides, of course, but there's a huge task ahead for us, and so lots to learn. And I think we need to engage those who are so deeply affected by the crisis, the Indigenous community, people who use drugs, and young women, for example, like to come up with solutions that work. And so we're kind of far away from 90, let alone 95, and we're not even looking at the fourth 90 or 95, but hopefully we'll get there. We need to get there. We have to do it. So yeah, if there's any researchers out there, experts out there, you know, reach out to us, like work with us, share your expertise, advocate with us, advocate for us, so we can also, you know, improve our situation. And hopefully when Canada's progress is talked about, you know, we're not ignoring a big chunk of the pie.
Yeah. Well, thank you very much, Sid. That worked out in terms of time very well. I really appreciate everyone's answers. So I just want to remind everybody that's on Zoom that you can either put your question into chat, or you can put it into the conference a question and answer thing, and we'll wait for questions. You can also, I think you can raise your hand. I'm not sure about that, but so I would, when you do ask a question, I just remind you to introduce yourself and who you'd like to address the question to, if you'd like to address it to everyone. Maybe just to start off with, while we're waiting for questions, I have one, and probably just in terms of estimates around the number of people living with HIV in the various provinces, which estimates are you going with? Are you going with the national estimates or estimates that you're making in each of the provinces? So Abigail, would you like to start, and then, or you can all jump in if you want. If you
as I lean in, we've been working very hard with PHAC to have a single estimate. So I think that's been a challenge, just having, you know, different data sources and different efforts. So we work very closely with them, and we produce an estimate together based on kind of the combination of methodologies, and then we have a range around that estimate.
Okay.
For BC, we're also working closely with PHAC. Our data is quite different, right? We have a better capture because it's a population level data. So for us, like when PHAC asks questions, basically, it's a little bit easier because everything is centralized, right? So we provide them with the information that's needed, and they have a model that estimates the prevalence of HIV in BC, I guess in other provinces as well. But the other the other steps of the cascade, they are all from our data.
Okay. Anybody else like to add? Sid, Alexandra, or Lee?
Yeah, like so we used our database to start with, and we identified all the people whose charts existed on our EMR, and kind of went into the active cases as the first 90. We didn't estimate, we didn't use PHAC data, again, because it wasn't available sub-regionally, like it was available as a province, but we're only looking at Saskatoon. So perhaps we need to work with PHAC or like local public health to develop that. That was one of our to-dos in the next step.
Thank you. Anybody else?
Yeah, sure. So in Manitoba, I think we've historically mostly relied on FACT data as well, but I think that Manitoba Health is also trying to work with the agency to sort of have a more consolidated estimate. But for our cohort, for our clinical cohort at least, our denominator largely is just people who are alive and diagnosed and have been in contact or like that are in the cohort. So it's certainly an underestimate in terms of the number of people living with HIV that are undiagnosed or just not known to the CAHR program.
Okay, thank you. The other thing, just in terms of a question quickly, because I don't see any other questions, just around migration. So you've talked about migration being an issue about loss to follow-up. Is there a way of estimating migration by looking at people that are coming into your province and looking at other provinces to estimate how many people are moving, for example, from Ontario to BC or BC to Ontario? You may not know who's leaving, but you know who's coming in, and would that be a proxy for that loss?
My ideal thing would be to have a way to link at least our data to the national vital stats, right? Because I can move to Ontario and unfortunately die in Ontario, and I would never know. I just know you're not in BC. And that, of course, I don't know if it's going to happen, but it would be ideal at least for us to know a little bit of the movements. I don't know if we can address totally, the issue of migration, depending on how that linkage is going to be, but at least we know the person migrated somewhere else and unfortunately died there. But if they are alive, then I don't know.
Yeah, that is a good point, actually. Abigail or anybody else?
I just wanted to add that PHAC will be releasing the provincial numbers for the International AIDS Society conference in July, and that'll be the first time they're releasing the first 90 by province and incidence and prevalence. And I believe they're also doing some subpopulation analysis, looking by gender. So that's an exciting thing. And these will, and they work very hard to try to normalize methodologies across provinces. So I think that they will be more comparable than in the past. As far as migration goes, we use kind of a variety of techniques like to estimate out migration, but we look at people using the health record data who has not accessed any healthcare services in the last 2 years. And that's what we use for an out migration, not just looking at HIV care. But of course, that's not 100% accurate. We also have in migration, like both of these things are issues. So to be able to calculate the undiagnosed fraction, you really can't include in your input data people who were diagnosed in a different jurisdiction, because when they come to your province, they already are diagnosed, they already know their status. So there was no time that they were undiagnosed in your province, right? So that's a big challenge. We have in Ontario, we have a very high migration, lots of people moving into the province. I think it grew like 200,000 people in a couple of years. And that's both from interprovincial and international migration. So we've been working very hard at this. And I know that nationally, there's been more of an effort to try to understand those previously diagnosed to improve the national HIV statistics as well. But it's an ongoing challenge.
Okay, thank you.
I'm just gonna add that it's the same challenge in Quebec. The surveillance program is collecting the area or the country of the first positive test to distinguish if it's a new test or a new diagnosis or not. But I mean, this is always very challenging. And
for BC CDC does clean the data when it's given to PHAC, because when we are preparing the 90s, we all get together and discuss the data, right? So yeah, we need to distinguish, were you tested and diagnosed in BC, or you already came to BC with the diagnosis? It's quite important. And the other thing, we had a conversation when PHAC releases the numbers, is that, as you can see, just by us, there's a lot of heterogeneity on how the data is collected, who is included in the data. And I think they need to disclose, right? The differences that you may see are totally driven from, by the data, or, is a true difference. So that is a little bit hard to distinguish, right? Because of the systems are quite different. Like BC also, we have free antiretrovirus, basically everything's free related to HIV care, and other provinces, there are co-payments. So, you know, if you have to pay for something, you might be less inclined to go and pay for it if you don't have money, right? If you feel insecure or something. But even though we have free of charge lots of things in BC, there's still some barriers that we see for people accessing care or even being tested. So those nuances of the data, I think, is very important if you're going to open the estimates by provinces. And I don't know if the territories are included, but it's important. That's something that really highlighted to PHAC.
Thank you very much. Does Anita, I'll give you an opportunity to ask a question, or?
Sure. So I was reading an article that was published. It's about developing databases in Newfoundland to better understand the HIV care cascade. And so it talks about how developing databases, administrative databases, is a very complex process. And I was wondering how important it was to you when you were developing your administrative databases, for some of you, to merge that data with cohort data, and how that can contribute to better understanding the cascade of care, or possibly even clarifying some gaps or missing information or confusing information within administrative databases.
That's a very complex, costly, time-consuming. We have a team of data analysts that do that for a living, let's say. They are really into understanding because every time we have linkages, right? Something might come up and the data might look a little bit different. And there's a lot of data quality checks, right? That has to be made. And it didn't happen like this, right? There was a lot of advocacy also with the government saying how this is important, why this is important, so that, you know, the government would understand, you know, the importance of having a centralized administrative data that we can provide them with answers. If some population, let's say the northern part of BC, they're not doing so well, we can identify that quickly and maybe point it out, like maybe looking here, like this is probably the reason why it's not doing well. So it took a lot, I'll have to say. And I hate to say, like, it was a big group of people, right? Was not just one, but well, we were led by Dr. Montana, but it took all health authorities, the government, researchers. Is a big, big enterprise to get this data together.
Maybe I can just add that the other challenge with getting clinical data and cohort data, for example, the Quebec HIV cohort, we changed the name to be able to include clinics that are outside of Montreal and more clinics, to be a bit more reflective. But it's challenging. The smaller you get and the smaller the clinics, the harder it is to actually maintain a database and actually participate in these kind of efforts. But meanwhile, these are often also the clinics who may have more struggle, and the patients may actually have less access to HIV specific care. So to have data that is going to reflect everyone's situation is harder. So cohort data are very useful for larger clinics and larger centers, but gets more difficult for other clinical settings.
I think everybody here, and probably our way, especially from thinking from a researcher's perspective, is like we make it work in the moment as best as we can. But without overlying health laws that support it and regulations, it's incredibly difficult and hard to maintain. And some provinces also have health laws that restrict it. And you know, these privacy laws are getting, you know, and for good reason, privacy laws are getting more strict. But as privacy laws get more strict, it's harder to link and share data. I think that there are ways for us to overcome this by using, you know, complex encryptions that we should be moving towards. But we're going to have to become more innovative, and we're also going to need more support from policymakers and legislators to be able to not only permit it but make it happen. They made it happen for COVID within a couple months. They changed the law for the Health Policy and Protection Act in Ontario within a month, right? So we know that it's possible for them to do this. They created an entire new database for COVID, where things that we've been asking for HIV for years didn't come to fruition. So I think that, you know, as much as we want to make it work in the moment, I think we need larger advocacy, and especially as we're talking about, you know, how do we know if someone moved from Ontario to BC? You know, and there are other jurisdictions in the world where you have a national database and you know exactly where people are at any point in time. And, you know, there's no technical reason why that's not possible here. It's only because of our laws and legislation.
Sid, you're in the infancy of your, so it seems we are at 5:45. We're at the end of our session. So thanks to all the panelists for contributing. It was a really rich and great discussion. Bob, would you like to add anything?
No, I just want to also thank the panelists. I really enjoyed this opportunity to ask you questions. It's nice to see you over Zoom, and I wish we were in person, and look forward to meeting everyone next year. So thank you again. And thank you so much for Anita for co-chairing with me.
Okay, so we do have a comment, which is great session, everyone, and productive discussion. So that's nice. Lawrence, did you want to add anything to end the panel?
I would just like to express my heartfelt gratitude for accepting to speak at this panel, and to you and Bob for moderating the panel. It was excellent. I've learned so much. I feel like all what you have said is a missed opportunity for a paper, because everything you have said is so educative and so informative. So thank you all once again. Bye, everyone.
Thank you.
Thank you.
Bye-bye.